I'll move on to the next topic on Femto and zepto capsulotomies. Okay, I have no financial interest in this. So femtosecond laser capsulotomy. I'm just trying to show you the no financial interest, but this is the Alcon platform. Now I use the Zimmer platform, but then this is the view which you will have. There is a PI, patient interface, which you use to applanate on the eye of the patient, and this is a contact method. And once you applanate, you will get these indicators. You can adjust the size of the capsulotomy. You can adjust the types of cuts which you make. It can be cylindrical, it can be horizontal cuts, multiple cuts, you can number them, and adjust the location of the incisions also. Better be clear corneal because it doesn't go through hazy cornea, or large arcus it doesn't cut, and towards the limbal area also it doesn't cut well, so be on the clear cornea. And this location, according to the pupil size, you can adjust the location of your rhexis, but once it has captured the limbus margin, it centers by itself. And if the pupil is decentered, let the rhexis be there. But if the pupil is too small and it is going to cut through the iris, then we have to manually change the location of the rhexis margin. And once that is finished, we will get the OCT of the anterior capsule. Now this is a good dock. The space between the edge of the dock and the sclera which is seen is uniform, and that's why you see a straight line here, which is the capsule is flat and stained, and this is the area where you get the laser into the nucleus. And you leave around 500-600 microns below as a space where you don't do laser between the nucleus and the capsule, so that you don't hit the capsule. And here also we see the incision. We can place it according to the area which is clear, and once that is done, the firing starts. The capsulotomy happens first, then the nucleotomy. It can be nucleus softening into small grits of nucleus, you can make it, or any pattern of your choice. And once that is done, it is released. And this is a look on the table. Mostly nowadays, after everything is titrated well, the capsule is freely floating. But to make sure that it is complete, I do it in a circular fashion, so that some bridges or some connections in between, if it is there, that is also taken out cleanly. And this is the look after this one. It is so well centered and so circular, and the positioning of the IOL will be the most perfect, ideal thing which you can expect. And when we face hypermature cataracts, main problem is that the patients cannot focus on the light so very well, and so the placement of the PI will be slightly difficult. We may have to block the patient. And see here, this is not a very centered dock. See, the sclera here is seen more, but still we can center the capsulotomy manually. But the problem here is that there is free loose cortex and even milky cortex inside. So here, when the capsulotomy happens, if some area finishes off first, the fluid starts leaking from there, and once the fluid starts leaking, two things happen. One is the level of the capsule goes down, and also the milky fluid comes into the anterior chamber and blocks the laser. And in these kind of white cataracts, the laser doesn't go through and the nucleotomy does not happen, and you mostly will end up with a partial capsulotomy here with some attached laser. See, this is the way you can have the milky cortex coming out into the anterior chamber, and then the laser passing through will be more difficult, and you will get incomplete cuts. So whenever I do a mature cataract, I always stain over the capsule, so that I can identify where there are connections. If there are connections, I would just not pull. Sometimes if you pull, you may leave tags there. So I will just include that area also and take a see. Now you can see one small tag which is there, but later on that also can be managed, and you will get almost a circular rhexis. But in this case, if you can notice, this is the only attachment. All the rest is free and it is floating. So what I do is, just like a rhexis, include this area also within the rhexis. So I am going outside this, because there will be some areas where the laser has fired and there will be weak areas there. So that will tend to extend during your phaco. So this will become little irregular here, but still that area, if it is included in your manual tear, then that weak area is gone. The major advantage of Femto in this kind of subluxation is that we can manually place the rhexis margin centered to the lens. So the lens, if it is moved to one side, if the rexus is centered to the lens, you will have adequate. So here you can have, see the positioning. Here the lens is subluxated here, and so you can move it away from the area of subluxation. You can have more anterior capsule free here, so that you can apply the capsule hooks and the easy placement of the capsular tension ring and all those. In small pupil, it's not worth it doing if it is less than 3 millimeters. But if it is 4 millimeters, still you can do a capsulotomy. This is a 3.6 millimeter. That is in some machines, that is the minimum you can do. And you can continue with phaco if it is a soft cataract, and the pupil becomes further small. It is more difficult actually with a small rexus to go on. So ideally, I would put iris retractor hooks and enlarge the rexus, which we have done, and then proceed. Here I have done it completely with the 3.6 rexus, and the IOL, accidentally it is opening within that rexus margin, which is not an ideal thing to do, but still that rexus margin holds. It doesn't break. A 3.6 and a 6 millimeter goes in through that. So it's not as weak as we think it is. It is quite sturdy. And then I extend it. But now we have this Zimmer machine, which can be kept in our own cataract OT. Need not go to a separate room, and it can be done sterile. The handpiece is sterile and the whole unit is sterile, and we can even place 2 paracenteses and put a BHEX ring of Dr. Suven, and then wash off all the visco, and then form the chamber, and then do this applanation gently, and you can finish off with the ring on. So, but it is a little big hassle. But previously it was difficult because the patient had to be shifted to a different room, and the sterility factor after opening the eye you had to shift. Now you can have sterile drape on and do the 2 paracenteses and go through the paracenteses and place the ring, and then bring the machine, the the handpiece can be moved, and bring the razor head onto the globe and then finish it off and take it out. If you have visco inside, you may need to increase the energy and titrate it accordingly, but you don't have to have visco. Because it is a 1 millimeter opening, you can always hydrate it and close it off tight, and then do the regular rexus. This is for information, because I don't do this. I don't do this. It is not worth the trouble. But sometimes, see, these kind of when the laser falls on this one, there will be adjacent areas where there are some laser spots which are there. So some weak areas may be there. When this lens goes in with a jerk, in this case, if you notice, it was a complete rexus here. So now, once the lens goes inside, you can notice, because of the pressure in the bag, the anterior capsule tore. The lens went into the bag, but the anterior capsule tore here. And so, remember, there may be laser spots which are adjacent to the cut area, which have been fired to the edges of the capsulotomy margin, and they may be weaker, and be slightly gentle with your femto rexus. And the cost factor is definitely there, and it will be almost double the cost of your premium IOL patient's cataract surgery. So that is coming down now, but then still it is on a high end. So please choose wisely whether you need to have this to do a rexus. But it is for a completion's sake, in a tertiary institute, if patients ask if you don't have laser assisted surgery, then you should be able to offer this. That's why we have it. So moving on to zepto. It is precision pulse capsulotomy. It is more electrical, and this is a handpiece which is connected to a machine. This is a disposable handpiece. It has a silicone cup with a nitinol ring there, metallic. Electricity is passed through this, and when you push this central thing, it bends. And this goes into a 2.8 millimeter incision, and it can be placed centrally on the capsule. And then when you press, there is and this is released. The central push piston is released, and this opens out. And that can be placed on the center. And when we apply vacuum, this silicone ring holds onto the capsule. You can just see the edges of the capsule here. I'm trying to center it. And after that, see the edges, there will be some suction on the capsule. And you'll see some folds on the capsule which are forming because of the suction here. See the lines? So, and then the energy is delivered, and it is so quick, and it is one shot, it makes a complete rexus with the electrical pulses, low energy, fast electrical DC current which is passed through, and you get a complete rexus here. And it is simple, easy, and it is cheaper than your Femto, but I don't know, somehow it has lost its fancy. Nobody uses it nowadays. But here also I had a problem because see, I just did a hydro dissection and a regular case, and I decompressed the bag. And just after that, look at this area. This area, the capsule is open. And I will show you more. Look at these two edges of the capsule here. It has opened up. Just I did a hydro and just did decompression of the bag, and the capsule tore off. So all these have weaker areas, and our manual capsulorhexis is superior in strength to most of these additional instruments which are. So our next speaker, Dr. Naren, had to leave because of an emergency. So I am going to deal with his topic also of weak zonules, capsulotomy in weak zonules, and capsule stabilizing. See, these are no zonules. So here you may get vitreous in the anterior chamber before yourself. So before doing a capsulotomy, we have to clear the vitreous from the anterior chamber. Once the vitreous is cleared, this area is plugged with dispersive viscoelastic. So when you put dispersive viscoelastic, that area gets plugged, and then you can put your regular visco on top of your anterior capsule and continue with your rhexis. So here many times we realize that the subluxation is much more when it dilates fully on the table. So it may not dilate completely, you may not realize it on the slit lamp, but see the area of subluxation there. So doing a capsulorhexis is difficult. I will come to that in the next case. But capsule stabilizing devices can be applied well only if you have a rhexis. So that is very, very crucial. This is a capsule hook which goes up to the equator. So this is long and the tip is blunted. There are other ones also which is made by MST, which is broader. It goes into the equator. So that supports the equator of the bag, and you can delay the placement of the capsule tension ring. Again, the placement of a capsule tension ring, the presence of a rhexis is mandatory. So once the rhexis goes inside, I use this forceps again. As Dr. Amit was telling, use of these micro rhexis forceps is very, very important and crucial. Please have it in your armamentarium. And after placing the CTR, I release the hooks and then place the lens in the sulcus and then capture it into the rhexis margin if possible. And this is another case which is a subtle, very subtle subluxation, anterior subluxation. You don't see the margins, but the chamber is very shallow, and there is a loose zonules all around. So here again, while starting, you will see the movement of the lens. This will indicate that the zonules are very loose all around. So sometimes you may not be able to complete it because it is so convex. You may have to approach the capsule from different locations. And if it is too loose, you will see while puncturing itself, it is difficult. You will see folds radiating from the puncture. So that again shows the zonules are weak in the periphery. So use very sharp instruments and microrhexis forceps if you need to, and complete your rhexis. And without rhexis, it is very, very difficult to place these kind of stabilizing devices. Now the lens goes into the sulcus, and because there is no PC rent, the bag will have a lot of viscoelastic, and I try to drain the bag as much as possible. And after that, with irrigation itself, I tap one edge of the optic under the rhexis, and this edge of the optic also under the rhexis margin. So the CTR is inside and the lens is in the sulcus, and the optic gets captured within the rhexis margin, and that makes the whole complex very stable, and the rhexis phimosis is also reduced to a certain extent. So this is a very difficult black cataract with a pseudo exfoliation with a lot of zonular weakness. See the movement of the lens. When you touch itself, it keeps moving. So that is when you struggle to even initiate. So using a very sharp instrument, we can slightly make a small nick and initiate a rhexis. But trying to extend it, it is very difficult to do it with one hand. So there is one technique which, because there is less counter traction, that is a problem. The zonules are not pulling it towards one side, and there is no counter traction. So I use two of these forceps. One to hold the rhexis margin in the opposite direction, the other one to pull. So this gives counter traction. So then you can proceed with your rhexis without creating more zonular dialysis or creating more traction on the already weak zonules. And once I complete, most of the times we'll end up with a very small rhexis because it will not tend to go to the periphery. If so, you can always extend. It takes a long time, but then take your own time, relax, give block, and then do it very gently, because without that it is very difficult to continue. And here I can place all my hooks on the iris, on the rhexis margin, and then place the IOL, and then the CTR goes towards the end, and the IOL, as we said before, goes into the sulcus, and it gets, now this is the way the optic goes into the bag while the haptics are in the sulcus. Again, I empty the capsular bag by aspirating the visco inside. Otherwise, you'll get a capsular distension very much. The capsule becomes very much distended. IOL gets pushed anteriorly too much. And now this is how we capture the IOL into the capsular bag. So just for to relax towards the end, when trainees start doing with hesitation, this kind of hypermature cataract, see, then it has started, it's going towards the periphery, it is very, very gently, slowly trying to pull, it's keeping on going to the periphery, decided to retract, again cuts once again, one more cut, now it is looking like 1, 2, 3, 4. That's a new flag sign which I have found out in this kind of cases, which is that, Amit, you know this kind of flag, new flag? Yeah, this is a Scotland flag sign, so I'm going to publish this anyway. So there are different types of flag signs which can be caused or whatever. So just to show you some, because we have 5 minutes more, just to show you some, this is one pediatric cataract. Lens was placed in the sulcus and left there. So this kind of a single piece lens gets decentered badly, and that can be exchanged, but then see what happened to the rhexis margin. See the kind of fibrosis which happens and the adhesion of the anterior and the posterior capsule. I'm trying to release this, doesn't work at all. But then if you look at this area, look at this small area. There is a gap. That is what God leaves it for you. And that's a small gap area, and through that, you can see Elshing's pulse already growing out through that. So that area I can identify, and visco can go into the bag. See the bag getting opened up? The visco can go all along and open up the whole bag. But still the center is so tightly stuck that I cannot release that, and I have to go around it and cut with the scissors and go around it and try to open up the capsule, the anterior capsule beyond it. So I am opening the capsule beyond it and then completing it till till I reach the periphery, and then I become very confident, and then and the last part I just snip off and then complete it off. So that is done, but then this has to go. So I pull so tightly I pull that I tear the posterior capsule here, see. So we have to be very gentle about all these things, and then finally I ended up getting the anterior capsule. So anyway I have to do a posterior capsulotomy. So I extend that and make a posterior capsulotomy and then place the IOL in the bag itself. So here is something which is seen in many of this shallow anterior chambers, PACGs and all those. See these anterior extended aberrant capsule, anterior capsule on zonules and anterior capsule. When you do a capsular rhexis, you will go into these zonules and then it will not progress as you want it to. So when you see these, please release them off with a blunt maybe a cyclotist spatula or a blunt Sinski. Don't damage the anterior capsule. It can be released off. So now you can see me trying to initiate a rhexis. It goes into that and then it doesn't proceed as we want to. So please release the attachment in the anterior capsule and then proceed. So this we have seen in quite a few cases only, but this is the regular exfoliation which you see on the anterior capsule. This is not pseudo exfoliation. This is the true exfoliation. He is not a glass blower or anything, but then he is just a manual worker. But then you see this kind of the exfoliated anterior capsule. So don't take it as something else. It may be there. So it can be just ignored. You can just go through that and complete the capsular rhexis. You don't have to. This is just for demonstration sake. I am trying to bunch it up and take it up and all those. Beyond that, you can just see the whole thing is being bunched up now. And then the capsular rhexis is started separately on the capsule and finished. So just to show you that even if you think that your manual rhexis is quite good, be gentle with your anterior capsule and your rhexis margins. Otherwise, see the rhexis margin is complete here. So I'm trying to aspirate a little bit of cortex there. Rhexis margin is still intact here. See, look at this area here. But if I stretch it so much, even this can tear. So please do not stretch very badly these kind of capsules. And thank you very much for going all the way through this course, and we have finished right on time. We have 2 minutes left. We can take 1 or 2 questions if you want to.
Maybe a small comment. In a femto capsulotomy, in a small pupil, while you may not choose to do a device in the beginning, but once the femto is done, it's always wiser to use a device. Because
Always.
that pupil is going to come down. And that capsulorhexis or capsulotomy is not really very secure. So if you want to do any manipulations after that, what you choose to use iris hooks or an expander, it's always a good idea to use.
Absolutely, absolutely. I don't find any reason trying to do a phaco in a small pupil. There is no reason at all without
not a
seeing
phaco,
anything.
you're talking of a femto.
Even then, after a femto,
Yeah.
to continue on in phaco is not at all necessary to do. Why should we do? There are expansion devices which are available, see and do. In cataract, it is almost everything you can see while you are trying to do a cataract surgery. So, use devices made in India once, rings, hooks. Orolab makes iris hooks which are very small and cheap. Suven makes no financial interest for me in this. He makes BHEX rings which I am using now regularly. My usage of hooks have come down drastically. I use it only for very intumescent and small pupil cataracts where I want it to extend more than 6 millimeters. I want to see the peripheral bag also. Or in a capsular PC rent where I want to extend more on one side and see. Otherwise, almost all cases are...
Dr. Minu, I just want to ask the audience, how many of you all have your micro rexes and micro vanas in the cataract set? So still the number of people using it is very less. I please advise all of you all, go and get a 25 gauge micro rexes, micro vana set, keep in your cataract set, and you will see life changes so much when you're doing the rexes.
No, we all don't have any financial interest in that. Epsilon makes very good ones. Indo-German makes very good ones. These are the two which I know.
Bangalore Cardio Care. I used Epsilon, is very expensive, but Minu can afford it.
Expensive
Yeah.
is one side. Cheaper ones which will
Long
break off,
lasting.
which will break off easily is on the other side. This lasts longer.
Yeah.
5,000 you buy, it will break off in 3 months.
So
If you
Cardio
buy
Care,
for 15,000, it will last longer.
Cardio
So,
Care. So Cardio Care, they have a very good material. I have used different companies. Cardio Care gives you one instrument for 3,500 to 4,000 rupees. So if you take both combined together, he'll give you for 6,000-7,000 rupees. But this is very, very good. 25 gauge through a side port, and what one tip Minu was telling, the bent MVR. See, Aurolab, I don't have financial interest, but Aurolab's bent curved MVR, the diamond sharp is so long that when you try to do the side port, it ends up in a long side port. So you should know how much the diamond length you want. The side port should not be very long, otherwise it will be difficult when you are using the bimanual or doing the rexes. So some tips here and there. Thanks.